Welcome to the IDEX Continuing Education Series.
Well, hello and welcome to the next in our IDEX Continuing Education series. Today we're going to have a chat about SDMA and more specifically some new information we've got. We're looking at what happens when we've had a mildly increased SDMA1s, what can come from that. Very briefly with SDMA, it's a marker of glomerular filtration rate, just like creatinine is. Three big differences though. It's more tightly adhered to GFR than creatinine is. It goes up significantly sooner. So with 40% loss of GFR as opposed to 75% with creatinine. And the third is it's not affected by lean body mass the way creatinine is, but we still need to look at it as a marker of glomerular filtration rate. So what we're going to look at today is, if you've got a mild elevation, what does it mean for the future? Going through some persistence data and then having a look at, when should we be doing rechecks? I think probably the thing that maybe causes people the most potentially confusion with SDMA is when you have a patient that you're doing bloods on for some reason. It's a wellness screen, a pre-anesthetic screen, bloods for some other reason, and you find an SDMA mildly increased when that patient has no clinical signs. Sometimes they have a normal creatinine, their urine is normal, and so it raises that question of, well, is this significant or not? What are the chances that it's going to stay persistently increased? If the creatinine's normal, what does that mean? What should I do next with this patient? So that's why this study was done, to try and help answer some of these questions, to look at, to try and answer the question of like, okay, well, if the SDMA is mildly increased, what does it mean? And one of the benefits we have at IDEX is we have lots of data. So huge numbers of SDMA samples have been run. And so then we can take a look at those and look at the trends and patterns that we can get in the longer term to try and give people confidence of what does this actually mean. So what this study looked at is patients, dogs and cats, that had had SDMA performed. Over 5 million pets had this done. So 3.6 million dogs, 1.6 million cats. To be included in this study, we needed to narrow it down to include patients that had multiple blood samples. So they needed to have at least 3 SDMAs performed that were paired with creatinine. And the first sample had to be normal. So within the reference interval for both SDMA, so less than 14 micrograms per deciliter, and the creatinine also had to be normal. So you can see the numbers there for both dogs and cats. So those numbers came down once, the numbers of patients. So 16,500 dogs and nearly 16,500 cats. So we just wanted to make sure that we were looking at patients that started with a normal glomerular filtration rate, and then we could evaluate what that mild increase in SDMA meant. So with those 3 samples, as we say, at time 0, they had to have SDMA and creatinine within the reference interval. At time 1, they had to have an SDMA above 14 and in that mildly elevated range, that 15 to 19 range. Then at time 2, we looked at to see whether SDMA was still elevated or whether it dropped back into the reference interval. So to be considered persistently increased, both the T1 and T2 values for SDMA had to be over 14. The reason why we started with the 0 sample being normal, as we said, is to try and say we had patients with normal renal function to begin with. That time between T1 and T2, could be, T1 around about sort of 14 days or so, and then T2 around about, within a year after that. So we're trying to get a good range of samples there. Then creatinine was brought into that equation. Again, we had to have 3 creatinine results in the patients with persistently elevated STMAs at T1 and T2. So we were looking at to see when did the creatinine come above the reference interval, or did it go above the reference interval? So with that, we had the sort of 16,500 dogs, nearly 16,500 cats, and then you can see the numbers that we were able to compare the creatinine with that. We're trying to look at a very particular group of patients in this setting. From this study, there were 4 key takeaways, and we're going to look at these all in a little bit more detail. But the first one is that if you have that single mildly increased STMA, there's a 72% probability that the STMA will be either persistently increased or increase again within a year. Of those patients with the mildly elevated STMA, 81% of them at the beginning had a creatinine that was within the reference interval when the STMA was first increased. By the time a year had gone by, only half of the dogs had an increased creatinine, even though they had a persistently increased STMA. And the other thing that they were able to demonstrate is that the probability of identifying a persistent increase in STMA, you didn't need to wait a long time to do that. Even 4 weeks was enough to demonstrate that. So if we look at this first one, so after that single mild increase in STMA, so in that 15 to 19 microgram per deciliter range, 72% of patients had an increased STMA a year down the track from that. So it's important to know that that is telling us that these patients have a persistently reduced glomerular filtration rate, which means that we can try and do things to help those patients out. So if we look at the group as a whole, so 48% had an STMA that was still elevated at time 2. 52% of them had an STMA that returned to the reference interval within that period. If we look at that first group, it's important to, we can break them down a little bit more to put that 48% of the population into context. We can get more information out of that, and we can see that here. What this slide demonstrates to us is that, you know, if you have a patient with a normal STMA at the beginning, there's sort of a 9% probability that they might have an increased STMA, you know, within a year down the track. But you can see that within the group of that 15 to 19 range, at that first T1 sample, if the STMA was increased, the probability that the STMA is going to stay increased increases the higher the STMA is. So if we compare that group as a whole with the mildly increased STMA at the beginning compared to those that were normal, it's a 5-fold increased risk of persistent increase in STMA by having that increased at T1 compared to it being normal. So it means that even with these mild elevations, it carries significance. And as I say, if it's even a little bit more increased with that, we need to pay attention to it. If we then look at the 52% who the STMA returned to normal sometime in that first year, this can happen sometimes. So you'll have a patient where you see it's increased, you recheck it at some stage and it's back to normal. There's reasons why this can happen, and sometimes people think, oh, maybe that first result was some sort of lab error, but there's reasons why the STMA could be mildly elevated and then go back to normal. This could be things like a patient that was dehydrated that's been treated with fluids, a patient with pyelonephritis that's been treated with antibiotics, a patient with hypertension, which can have an adverse effect on kidney function, that's had its blood pressure managed. We can also get patients with some loss of renal function that they can have some compensatory mechanisms that help sort of, at least in the short term, you know, improve the glomerular filtration rate, or there's been repair from a mild injury. We can also sometimes get patients with mild chronic kidney disease that their levels will vary a little bit from time to time. So you'll see them within the reference, at the high end of the reference interval sometimes, mildly above the reference interval at other times. So, there's a number of reasons why that level of STMA can vary. But when we look at these patients, this 52% where the STMA went back to normal within that first year, it doesn't necessarily mean that the problem has been resolved. What we can say that the GFR dropped back into the reference interval for a period of time. But there is value in following these patients up even after that STMA has gone back to normal. Because when we look at that group of 52% of patients whose GFR went back into the reference interval for a period of time, nearly half of that group had the STMA increased again within 12 months. So it's telling us there is still that value, even if that STMA at time 2 dropped back to normal. If it was increased at time 1, we need to monitor that patient in the longer term. So, if you were going to, even if the GFR had gone back to normal, if that patient was going to have an anaesthetic, we should check the STMA again to assess GFR. If we're going to start them on non-steroidals, we should reassess their STMA, so we can assess their GFR, because we need to consider that maybe that patient, could have, compromise of their renal function in the longer term. So if we look at that within that 12 months of a single mild increase in STMA, if we had the 48% who had a persistent increase, if we add on the 24% who at T2, the STMA went back to normal, but then later on increased again, we have 72% of patients that could potentially have ongoing impairment of kidney function with that. So this is really important to consider when we get that first mildly increased STMA. So then we need to have a look at creatinine, what it's been doing during that time. So we know based on the STMA that these patients with persistent increases have some reduction in their glomerular filtration rate. So we're looking at this to see, well, is this telling us that even if the creatinine was normal, that STMA is an earlier marker of kidney disease and potentially more sensitive with that? So if we look at the creatinine in these patients with that mildly increased STMA, at the beginning, 81% of those patients with that mildly increased STMA had a creatinine within the reference interval at that time. So it would suggest that probably we're in an earlier stage of a loss of GFR. Then if we have a look, but then if we look further on, you can see that as time went on, at 6 months, 36% of them had an increased creatinine, at 12 months, 48%, and that continued to increase. But even at a year after, only around about 50% of dogs and cats had an increased creatinine by that stage. It's telling us that their GFR has continued to decline a little bit. Because remember, we said, STMA increases at about 40% loss of kidney function or reduction in GFR. Creatinine increases at about 75% loss. So I think we can take confidence from this that if the STMA is persistently increased, we do have a patient that's got some degree of loss of kidney function. It may not yet be at the point where their creatinine is going to increase with more marked loss of function, but we can do things for that patient to try and slow the progression. So, as we said, in the vast majority of patients, STMA was the first indicator that their glomerular filtration rate was falling. And even at a year, only 50% of them had that increase in creatinine. So, they're patients that we can draw the conclusion that their renal function is continuing to deteriorate or their glomerular filtration rate is continuing to fall. So we've missed an opportunity if we haven't started to take steps, to manage that patient, to try and see if we can find a cause for that reduction in GFR, and to try and take steps to slow the progression of kidney disease. So the earlier we can take action to do that sort of thing, the better we're going to be managing our patient. The other thing we could take away from this study is looking at the timing for a follow-up if you've got that mildly increased SDMA. In this graph, what it's showing is, the level of increase of SDMA is on the x-axis, where the SDMA was, or the percentage of patients that had a persistently increased SDMA after. You can see with the sort of the teal circles, the purple triangles, and the green squares, that whether you recheck the SDMA a month after, 6 months after, or 12 months after, you're getting the same message from that. So, if they were going to be persistently increased at 12 months, they were also increased at 1 month with that. So the importance of that is to say that we should test within a month of finding that first mildly increased SDMA, because if we can demonstrate that that's persistently increased, we know that we've got a patient that we need to treat as having some reduction in glomerular filtration rate. So, managing things like blood pressure, good diet, managing proteinuria, being careful of drug selections and things like that. These are the 4 sort of conclusions we talked about before from the study. So let's have a look at what these mean. So we said, after that single mild increase in SDMA, a 72% probability of a recurrent increase in SDMA within a year. So what it's telling us is we need to investigate and follow up. Even if that SDMA drops back to normal at one stage, it means there's been some restoration of glomerular filtration rate. It doesn't necessarily mean that the problem is resolved. With the 81% of the patients, who had that mildly increased SDMA initially, had a normal creatinine. But what it's telling us is, by looking at that data as we stretch it out, that increase in SDMA is warranted to follow up, that we shouldn't just be like, oh, everything else is normal, we don't need to worry about it. Because 1 year is a long time for a patient like this, if we could have been taking steps sooner to try and help, manage things and look for a cause of that reduced glomerular filtration rate. If the SDMA is persistently increased, we should look for a cause of it, so that we can try and see if we can, find something that we can manage to see if we can slow the progression of disease. And the 4th is the probability of identifying persistent increase in SDMA doesn't change whether they're checked at 4 weeks, 6 months, or 12 months. So there's value in doing those rechecks sooner so that we can identify those patients with a reduced glomerular filtration rate. So I think the things that we can take away, we don't want to ignore a mildly increased SDMA. At a minimum, look at the patient, look for other signs of kidney disease, and do a urinalysis. And keep in mind that a normal creatinine doesn't mean there isn't a reduction in the glomerular filtration rate. We need to recheck that SDMA, even if it's only a mild increase and everything else was normal. Because if it's persistently increased, we need to investigate that patient further. So the IMM protocol, the Investigate, Manage, Monitor protocol that you can get in the Directory of Services or through the ICE website, is a good guide as to what testing we should be doing in that setting. And keep in mind here, we've now got the SDMA recheck bundles, so a discounted price on the SDMA, from if you're buying it as a standalone test for the Catalyst. And by doing that, we're assisting in making rechecks cost effective for your clients. So thank you for your time today. I hope this has been useful for you, to show the value in SDMA and that persistence data. Of course, if you have any questions, don't hesitate to reach out to us. You can speak to one of our internal medicine consultants or myself, and we'll look forward to seeing you on our next continuing education series talk. Thanks for your time today.